So Aishwarya, you're done with the first slide?
So no history of similar complaints in the past, no history of fever, weight loss. Okay, I'll shift to the second. Yes, sir, fine.
Yeah, go ahead.
History. The patient consumes mixed diet, consumes well-cooked meal, normal appetite, no addictions, bowel and bladder are regular. Treatment history. Patient underwent detailed evaluation during zona infection and is seronegative. Lubricating eye drops were prescribed when he consulted the ophthalmologist for his current ocular complaints. Family history, not significant. On examination, right eye, best corrected visual acuity is 6 by 6 parts and N6. Adnexa is normal. Conjunctiva, there's mild congestion. Shermer's 2 test shows 5 is 5 mm. Cornea, multiple, fine, fresh, keratic precipitates are seen inferiorly, and the corneal sensations are intact. So should I go again with the second slide? Should I?
No, this is fine. Carry on.
Yes. Sclera, AC, iris,
Note
normal.
that class.
Intraocular pressure is 32 millimeters of mercury by applanation tonometry. Pupil single, central circular reacting to light, both on both direct and indirect right reflex, and bilaterally equal. Lens clear. Vitreous query. Vitreous cells. Vitreous haze grade 1. Fundus examination. On dilated fundus examination, the view of the right eye is hazier as compared to the other eye, with vertical cup disc ratio of 0.4, with healthy neuroretinal rim and vessels, with multiple flat, non-elevated, yellowish white lesions present circumferentially and seen coalescing in the far periphery with indistinct margins and associated subretinal hemorrhages. This is the fundus photographs. Now the left eye, the best corrected visual acuity is 6 parts N6. Adnexa, conjunctiva, normal. Shermer's test, 30 millimeters. Cornea, normal. Anterior segment, normal. Pupil, single, circular, reacting to light and bilaterally equal. Lens and vitreous, lens clear. Vitreous media clear. And on dilated fundus examination, cup disc ratio of 0.4 with healthy neuroretinal rib and foveal reflex present, and periphery with a normal rim. So my provisional diagnosis is acute retinal necrosis.
Do you have a photo of the left eye?
Sir, only yes. The second slide. Only comparable photo, the right and the left eye. Not
Sorry, I can't see the photo of the left eye at all.
Because of the yes, now you'll be able to see, sir.
Let's go back one slide. Okay. Come, one ahead. You can continue, no problem. Chalo.
Yes, sir. So the provisional diagnosis is acute retinal necrosis.
So what is the level of vitritis in this patient?
Sir, with the cup and the disc is seen, the vessels are seen. The retinal nerve fiber layer is also seen, but little hazy. So 0.5 grade of vitritis, we can say, because it is slightly dull as compared to the left.
Okay. Okay, so what did you do next?
So we examined the periphery, like after
That
the
is fine. That is fine. I got
Okay,
the
okay.
ocular examination part.
Okay.
So what have you done next from the point of view of diagnosis? I know, sorry, I don't know. Where do you work?
Sir, at BARC hospital.
Okay, no. So when I ask you, obviously I take into account where you work. I mean, it's if you work in a place where there is no PCR, I can't expect you to do PCR. So what have you done next? After seeing this patient, what did you do next?
Okay, so we can
Yes, sir.
yes, we
You
can
must,
go
when you
for
saw this patient, you must have had some DDs in mind, no? So how
yes,
did you
sir.
start eliminating them?
Okay, so sir, with this kind of
So what were the
presentation,
two main differentials that came to your mind when you saw this patient?
sir, uh, that is first acute retinal necrosis came into my mind.
Okay.
Then progressive outer retinal necrosis also came, but
Excellent.
with the seronegative history,
Hmm.
as the patient is seronegative, I ruled it out. Like I thought mostly it might not go that way with progressive
Perfect.
outer retina. Then
Perfect.
yes, then with this kind of presentation, actually there are hemorrhages also. In acute retinal necrosis, there is mostly coalitions and not hemorrhages is little rare. So I thought
So
it
it
can be
would,
CMV. See, it
correct.
might be CMV retinitis.
This is not CMV.
This is not CMV though, but
Because CMV usually is more in the posterior pole. There's lots of
yes,
hemorrhages, and there's a very distinct involvement of the venous system.
venous system, yes.
And the
So
vitreous is clear. Most important thing in
yes,
CMV is that the vitreous is clear.
this is clear. Okay.
Whereas here the vitreous is obviously not, well, it's not hazy, but it's not clear either. So if at all, this would be the early phase of ARN where you have multifocal areas of retinitis, which then slowly start to coalesce
Yes,
together, but
yes.
haven't started coalescing yet.
Hmm.
Okay, bolo, next.
So what about this
What did
third
you do?
image?
So that is at the bottom, there is apparently some of these lesions seem to be starting to coalesce. Or
Yes.
obviously you can't make out on this, but is there something pre-retinal which is, did you feel that there is a pre-retinal mass which is there at the periphery? Not sure.
No, sir, not sure.
Okay, fair enough.
Yes, so it doesn't.
Okay, give me some of the other DDs that you thought of. In the extreme left side, that is multifocal retinitis. That is very clear.
Yes, yes,
And the
sir.
middle one as well is multifocal retinitis. So don't worry. Okay. Then what are the basic tests you did systemically? Systemically, what tests did you do to find out to go ahead? How did you rule out immunosuppression first of all? Because if you're talking PORN, if you're talking CMV, the presence of immunosuppression is critical.
Suppression is yes, sir. Sir, see, with the
How did you rule
presentation
out
there is
lymphoma?
vitritis. In immunosuppression, there won't be vitritis. Yes, sir.
Correct.
Sir,
So how did you rule out lymphoma,
first of all, patient
leukemia?
history.
Correct.
Sir, we started with the basic routine examination. The blood tests were done. Then, the patient already has has a he was already evaluated when he had zoster previously.
You only
So
ruled
he's
out
already
HIV. Fair
seronegative.
enough.
Yes, yes. So
Correct.
we
You
have
have
ruled
ruled
out
out
HIV.
HIV. Agreed. But what about the other causes of immunosuppression that you might come across in your
That
OPD? This be an initial
sir,
presentation
we
like
can do a
leukemia.
X-ray. chest X-ray, HRCT to check
Of
for any lymph
lymphoma.
nodes associated with TB and lymphoma. Yes.
This could
And
be.
there is no history suggestive of any like there is no weight loss, there is no fever, right? That is pointing that towards something that might appear
Yes,
as if
sir
it
is
is
asking what
vasculating.
investigations you would like to do now. You have this case in front of you. So what
Okay,
investigation?
sir, I would like
specific?
yes.
So
So
on
I
a
like
very,
to
very, very ideal level, if you are at Harvard or Yale, the moment you see such a patient in the OPD, the next step he goes into the OT with you. You do aqueous tap or you do vitreous tap. You send for PCR. You see what comes up and then you start the treatment. But in Indian circumstances, that is simply not feasible. There is nobody around to do PCR for you, even if you manage to give them a sample. So
yes.
what would you like to do within our constraints?
Okay, sir, I would
Okay,
like
you have done
to
CBC. You have done Triple H. Next.
yes. We'll do chest X-ray, HRCT.
Okay, perfect.
Yes. Then HRCT, chest X-ray. Then we'd like to go with ocular investigation.
Yep. I think you have done all of that quite well. Don't worry.
Yes. Yes.
Chalo. So now, after doing all this, you have reached a tentative diagnosis of ARN. Now, what do
Yes.
you do?
Okay. So we'll start with uh, acyclovir or valacyclovir.
Correct.
800 mg 5 times a day for prolonged duration for 2 to 4 weeks. So we can actually, if possible, we can take a AC tap after that and check for the ocular antigen.
Okay.
If how is it responding to our treatment?
No, but then for that, you have to do an AC tap before starting treatment, na?
Yes.
You have some,
First
you
we'll
need
do
a
it.
reference to compare it to, na?
Yes, first before. Yes.
So you first, if at a very ideal level, when you go to write that exam, you need to write, I will do PCR to look
Yes,
for the
sir.
presence of what?
So look for the virus, presence of the genome of the virus, the
Which
DNA.
virus? Exactly. Which
Yes,
one?
yes. A double-stranded DNA अपना herpiviridae family, varicella zoster.
So which one? Which of them? How many herpes viruses are there anyway?
8. Sir, there are herpes simplex, herpes zoster, then
No, no, how many?
cytomegalovirus also.
Number.
8.
How are they classified?
8.
HHV 1, 2, 3, 4, 5, 6, 7.
2, 3, 4, 5,
So
6, 7.
HHV 1 is called HSV,
Hmm.
then is VZV, then is HSV 2,
Uh,
then is
yeah.
CMV, then is
CMV,
EBV.
BV. Yes, sir.
So you look for members of the HHV family.
Family.
Correct.
Yes.
And which are we likely to find?
Sir,
In a patient who is seronegative, what are we likely to find?
so we'll not find HHV5. We might find HSV2 and HHV3.
No, you will basically
Very
you will
good.
get only herpes simplex. It's very unlikely that
Yeah.
you will find anything else. Or you most likely you will get VZV. If you're very
Yes,
lucky,
it
you will
is
get
HSV3.
HSV1. That's it.
1 and 3. Yes. In
So supposing you
immunocompetent.
find HSV1 and HSV2, will that alter your diagnosis? Supposing now VZV is negative, but you
So it
find
shouldn't all.
HSV1 and HSV2, would you at least start thinking that maybe this could be something else? Could it be that these are more common in PORN, so therefore this could be early PORN?
So
No, it doesn't matter. Okay,
it
let's
doesn't.
not go there.
It
Okay,
was.
no problem. Let's not go there. Chalo. Then what do you do? After that, what treatment do you start?
So we'll start with acyclovir or valcyclovir. We can start acyclovir 800 mg
Hmm.
5 times a day for 4 weeks. Here we'll have to give a longer course.
Hmm.
4 to 8 weeks we have to give. We can start with valcyclovir.
Correct. I agree with you totally.
Yes, sir. And
What is the rationale for giving acyclovir? Once you have such severe retinitis, you're not going to recover visual function. So why are you giving acyclovir?
sir, there is some antigen which is exciting this inflammation.
Agreed.
So we want to
So even if you manage to control the antigen, there is
some
their
sort of
visual
inflammation. So we
prognosis
might give
is anyway very poor, na? Especially if the
yes.
posterior pole is involved. So why give it?
To prevent the complications.
Complication.
Correct. What else? Most important of all.
So it has
You want to
virus
make sure it
specific.
doesn't occur in the other eye.
Right.
The rationale of treating ARN is to make sure it doesn't occur in the other normal eye.
Yes, sir.
Ah, that's okay.
Uh,
Bolo, then. So tell me,
Then
what are some of the complications somebody just mentioned just now? What happens
uh,
once you have a
sir,
necrotic retina? What's likely to happen?
Vitreous hemorrhage.
so detached hemorrhages, detachment.
Correct, detachment. So
Yes.
what do you do? What do you do to make sure that detachment doesn't occur? You keep having a look at the
Having a
patient,
Regular follow-ups.
regular follow-up
and
of the
look for what?
patient.
What do you look for in regular
Any
follow-ups?
Necrotic areas.
Any?
whether it is
Correct. Somebody had the right answer, though I
Yes,
can't see their
Supriya,
face.
please be louder and clear.
To see the progression of the area of the necrosis.
Correct. So basically, at the junction of the necrotic areas and the regular areas, you will start noticing visible breaks. So that is what you have to look for and to see if any of those breaks can be lasered before you need to go in and do vitrectomy and catch Anuj Soni to put oil for you. Bolo, what else? What is the visual prognosis you can give these patients? You have to, your first question is going to ask you is that what will happen?
Sir, because since this is a rapidly progressive condition, if we have started the treatment early, then we can assure moderate visual function. Otherwise, we have to tell the patient that he might go like there will be a poor visual outcome. We have to warn him about it.
Correct.
Yes.
Barabar.
And then we also have to warn about the involvement of the other eye for which we are giving the
more
treatment.
important. You to guide him that in case he starts noticing any pain, redness, most important is episcleritis and scleritis. Moment he feels that eye is a little bit red also, he needs to come back and you need to dilate him and check.
Yes.
Correct. So what are the complications of, tell me, what are the complications of acyclovir? Now that you have admitted the patient in your hospital or in your nursing home, you say you have called the sister and said, give acyclovir. Now, what are you careful about while giving acyclovir?
Neutropenia.
Neutropenia.
Correct. How do you check for neutropenia?
Do regular CBC counts.
So what constitutes neutropenia? What is the normal level and what constitutes neutropenia?
60 to 70% is the normal level.
That is a normal proportion. Is normal CBC enough to look for neutropenia? Or do you need to do something else?
Absolute neutrophil.
Yes, you need to tell the lab to give you an absolute neutrophil count.
Neutrophil count.
Yes, correct. So that you come to know whether there is actual neutropenia or just his normal level is only so much. So why do these patients get vitritis? Your other bugbear is CMV. CMV patients never get vitritis. So why do these patients get vitritis?
So because there is inflammation, there is an antigen antibody reaction happening.
Why do these patients have inflammation and CMV patients don't?
CMV occurs
because they are immunocompromised.
CMV
You know,
occurs in
when the CD4
immunocompromised
count is less than 50, then we are mostly seeing CMV. I'm talking about HIV patients. So in
Correct.
those cases, there is the
But
body reacting to the
even
antigen.
even CMV means cytomegalovirus retinitis, means there is an active inflammation of the retina and of the blood vessels. It's not zero, but there's no inflammation of the vitreous. Why? Here there is inflammation of arterioles, of retina and vitreous. But why does
Okay.
CMV only produce inflammation of the retina and the veins and the arteries, but not of the vitreous? If you were to do a vitrectomy, what would you find?
PVD.
Because in CMV, the virus
We
particles do
literally
not
find virus
enter into the
particles.
vitreous.
Vitreous.
So therefore, they do not set up an inflammation.
Vitreous.
Here, they always
Uh-huh.
enter the vitreous. So the first thing that happens is vitritis. They've heard of something called chemokines and cytokines and things like
Yes.
that. No?
Yes,
What's
inflammatory
the
medium.
result of all that? So the protein coat of the virus acts as an antigen and sets up a antibody reaction.
Yes, very.
Correct. So, chalo. You know, I didn't understand one thing. When did he have this herpes zoster? How many days or months before this
Uh,
infection?
so that history is not clear. That was not given.
Oh,
He had
fair
it 2 weeks back, sir.
2 weeks.
Yes. Actually, the
Okay.
patient is a French tourist.
Oh,
Yeah, and so as Aishwarya mentioned, he gave history only of having zona.
hmm.
So he went to another ophthalmologist also, and because zona, we don't understand what it means, so we just did a Google search and realized that it is herpes zoster.
Hmm.
So
That is why this is the mystery of
and
Google
and
Translate.
his tap has PCR positive for VZV.
Wow, wonderful. Where did you manage to get it done?
No, patient, we went to Paris again.
Okay, you got it
And
done there.
so he's, yeah.
Hmm. Because it's very, very unlikely that anybody
Yes,
here could do it for you. Yeah. I don't think we have the primers only for VZV out here.
absolutely.
Hmm. Chalo. So what has been your learning from this patient? Tell me.
Sir, that first of all, whenever there is a complaint of floaters, we have to examine the periphery also.
Correct.
Because when he first went to the ophthalmologist, he visited a private practitioner. They have given lubricating eye drops. The fundus periphery was not examined. That was known. Like there were no photographs, nothing available. Now he got the periphery examined, and we got to know about the lesions in the periphery. Second, so there is the Sharma's test shows 5 mm for the right eye, and left eye it is normal. So there is a doubt. Maybe could be because like why is the difference that also I have a doubt. The
I don't think
difference in the
it's
Sharma.
relevant. I don't think it's relevant at all.
It's not
We'll
relevant.
focus only on
Okay.
the
Then
posterior part.
even a
Yeah, yeah.
younger.
For all these things, you have to
Okay.
get hold of people who spend the whole day doing this kind of drama. And in the end, prescribe the same eye drops. So I
Okay.
don't know what to do. Ah,
Okay. So the first thing is the periphery. Then second, uh, thorough examination, like systemic examination, is also should also be done whenever there is a query uveitis, any uveitis, anterior, intermediate, posterior. We have to get a systemic workup done, like look
correct.
as a whole. The patient should be worked up as a whole. Like if there is any other history suggestive of anything like fever. Now he's from France, so TB is unlikely, but still we have to work up the patient as a whole. Then he's quite young, so the visual prognosis should be linked to him properly. He's just 29 years old. So if it progresses and he loses this eye, So he has to be told to follow up with the ophthalmologist at in his country, home country, or anywhere else thoroughly, and should be regularly monitored. So the prognosis and the management should be explained to him.
Correct.
Other than that, yes, the role of PCR, genetics, genome sequencing in the early diagnosis of such diseases is the need of hour. Then,
No, that's okay. That's okay. Enough learning. As long as you learn 1 or 2 points of each patient, that's more than enough. You can't have one textbook per patient. It doesn't work that way in life.
and then, sir, about inflammation, you mentioned
Yeah.
like why vitritis, because and why not in CMV? So that point
So
also.
CMV patients are in general immunocompromised.
Yes.
So if the other important thing to realize is if you ever see CMV patient, CMV in any person, please look for evidence of immunosuppression. Because CMV simply cannot happen in normal healthy people. It just cannot happen.
Yes.
So
Yes, sir.
there is some focus on immunosuppression somewhere. Half the times it is because these patients are taking covert corticosteroids without even realizing. So they have
Yes.
been to some local GP who was given a whole bunch of capsules in a plastic bag and they don't know what it is.
Yes.
Or they've
Like
gone to one of these holistic guys who has told them take A, B, C, D, and there again you don't know what it is.
yes, sir. So there was this one case I have come into that where bleaching, like corticosteroid was used for bleaching prior to a function, and then that reactivated the lesion. Like CSR happened because of that. Means even in our general bleaching agents, corticosteroid, face bleaching, all those things. So yes, steroid
Practically
history.
everything contains some amount of steroid until proved otherwise. Anuj will tell you that one of the most undiagnosed problems is patients coming with cataract after using steroid skin cream. They use skin cream for eczema and for some other purpose or the other. Few weeks they use and back cataract. Anuj, anything you want to add?
No, so the Aishwarya, so what are the components of this ARN? Like you are saying this patient has ARN. So next time when you see a retinitis patient, what are the components which sir has already discussed? But what all will you see?
Sir, only the posterior segment, like entire patient as a whole, or only
The entire eye, not the patient.
sure.
The entire
So
eye,
we'll
what
see
are the
signs
findings
of
will be the anterior segment?
yes. So we will see signs of uveitis in the anterior segment. Any fresh, if there is any other fresh complaints regarding the anterior segment,
No, so
then
what type of uveitis you will see?
Is it granulomatous or non-granulomatous?
so
Granulomatous.
non-granular.
It's always granulomatous. Always. VZV always produces granulomatous uveitis. Always. Even if you see VZV anterior uveitis, it's always granulomatous. So if you see in your OPD patients with severe anterior uveitis but normal posterior segment, it is VZV until proven otherwise. Or of course TBA and leprosy and syphilis and all those things. But from virus point of view, it's always VZV.
Yes, Chinmay, you have something to say?
Chinmay is on mute only. I don't think he can hear you.
He has raised his hand, so I was wondering.
Oh, okay.
Yeah, what else in the anterior segment, Aishwarya?
So we'll see signs of iris atrophy in the so first of all, cornea, we can see any keratic precipitates are there. Pigmented keratic precipitates will be there. Then with the iris, there will be segmental, usually segmental iris atrophy. with herpes. Then mm, so cells, there will be
Yeah, that is signs
inflammation.
of
So
uveitis, anterior uveitis, sir has told granulomatous. What else? Do they complain of pain? Sir has already talked about it.
Congestion.
congestion,
Congestion.
yes.
Why they will have congestion?
So it will
Does it only affect the uvea and the retina, this virus?
so no, it
Maybe
can
cornea.
enable
Cornea
any
can be
hernia also. Any, yes. So even
See, sir already told that these patients will present with congestion, maybe due to episcleritis or scleritis. So that is very important because they may present just as scleritis if you don't examine the retina properly, and they will have pain because of that. So sometimes even you may see a patient who has pain more because you don't expect pain when you are seeing a choroiditis patient. Right? So scleritis is a very important point in this. Okay. What are the other components which you see? So do you want to take?
So Anuj, let's just take some of the questions that have popped up out here. So Ayushi Kejriwal says, can't see the slides, but I think that problem is sorted. Anusha says syphilis. So in an Indian context, syphilis has some very unique presentations, of which the commonest that you're likely to see is something called as a ground glass retinitis in the posterior pole. So this is not that. The other thing you will see is like coin-shaped lesions accompanied by intense vitritis. But those have a very distinctive look to them. So you can search for those. Supriya wants to know whether you want to do FA. I don't think there's any rationale to do FA in these patients at all. The fundus picture is totally clear and diagnostic, and no unlikely to be toxoplasma. Even though it's classically described as headlight in the fog appearance, there are no other scars, even though this could be de novo toxoplasma, but it's not usually likely to be so multifocal.
Okay.
Shaiban asks whether virus-specific action spares the healthy cells, and not really. All these viruses are reaching the retina through the vasculature. So they produce an arteriolitis first, then they spill out over into the retina and attack whatever is there. The same way with CMV and everything else. Preeti Gupta, we've already talked about second eye involvement. Second eye involvement technically is supposed to occur according to some very people who have way too much time on their hands and can spend time thinking about all this. Is they say that there is retrograde transport of the virus through the axons into the hypothalamus and crosses over into the other eye from there. I think it's a little far-fetched, but who knows? Time may prove that person right. But hematogenous sedent can certainly occur. Scorpio girl, what investigations can we do here? Unfortunately, really not much. Unless you're in PGI or AIMS where you have microbiology at your disposal 24/7, is very little you can do. Clinical diagnosis, if in doubt, always give acyclovir. Nothing to lose, but you can lose the other eye if you don't give acyclovir. Always give acyclovir and ask for somebody else to have a look. So Priyanka Ramraju wants to know why vitritis is absent, because there are no virus particles in the vitreous. Plus, immunocompromised to some extent, so there is no inflammation. Abhirami wants to know, should we consider endogenous endophthalmitis? Yes, certainly endogenous endophthalmitis is the definite differential diagnosis in this case. Definite, but it's unlikely to be multifocal. Usually in endogenous endophthalmitis, you just have one large focus somewhere in the posterior pole, and then you'll have a little bit of bleeding once it breaks through the choroid. and then you will have a mushroom-shaped thing as it breaks into the vitreous. So the appearance is slightly different. Nadi, I just explained to you why no vitritis in CMV and why it's there in ARN, because the presence of the antigen in the vitreous produces the inflammatory reaction. Role of prophylactic vitrectomy, I think only Sony can answer. Anuj, you want to take this? Is there a role of prophylactic vitrectomy? If there is, I'm not aware of it. Somebody wants to know, can you discuss choroiditis versus retinitis? So, in the general dictum is that bacterial and mycobacterial diseases tend to involve the choroid first because they are hematogenous. So they tend to produce a choroiditis first, which spills over into the retina. So you have a chorioretinitis. Whereas viruses such as HSV, VZV, CMV are primarily neurotropic. So they primarily tend to involve nervous tissue. So you always have CMV encephalitis and you can have CMV retinitis. Same way with HSV, VZV, these produce neural lesions in the brain and in the retina because these are all nervous tissues. They do probably spill over into the choroid, but the retinitis is so intense that I don't think anybody has even reached the choroid. So whenever, if you can able to make out whether this is choroiditis or retinitis, obviously the only way you can make out is whether how superficial you think it appears. If it's very superficial, you think in terms of retinitis. If it is deeper, below the vessels, below the retina, you think in terms of choroiditis, but that is not a very perfect way. Then you can have an initial diagnosis of whether this is bacterial, mycobacterial versus just viral. As long as the Bruch's membrane is somewhat intact, the vitreous is likely to be clear. In that case, again, it goes towards a choroiditis or mycobacterial infection rather than vitritis, rather than retinitis.
So why does toxoplasma then cause like a retinochoroiditis rather than a chorioretinitis?
Right.
Like
No, the hallmark of toxoplasma is necrotizing retinitis, not choroiditis. Toxoplasma is a facultative organism of the retina. Therefore, it produces retinal scars at the end of the day, not choroidal scars. All that pigment dispersion is because of RP proliferation, but it produces a retinal scar. So you always see that little retinal scar next to another active lesion, and that area you'll have a little bit of vitritis. So Vishal wants to know about intravitreal gancyclovir schedule and end point of giving injection. Honestly, there is no clear answer to that. You have to follow up until you feel that the infection is taken care of. But 14 days should be enough. Intravitreal gancyclovir is only for CMV. It has no rational and ARN. But usually 2 to 3 doses of intravitreal gancyclovir is enough. Or you can just give systemic gancyclovir or val gancyclovir for CMV, and you don't have to take the patient to OT. They can just follow up. So Priyanka Ramraju wants to know, can this be multifocal choroiditis? Certainly, certainly. It can be multifocal choroiditis. Even with the history of zona, it can still be multifocal choroiditis. It cannot be ruled out. Basic investigation for multifocal choroiditis has to be done in every patient. In India, of course, that means TB, but we have to be a little careful. Anything else, Anuj, you can think of?
So in the OPD, like when we are evaluating a case of uveitis, we ask us like a bunch of questions regarding tuberculosis, recent fever, trauma, joint pain, oral or genital ulcers, and all of that to rule out some of the common causes. So I wanted to ask, like regarding immunosuppression, is there any questions in the OPD or any systemic features Like just by looking at the patient, what all are clues that this patient might be immunocompromised? Like, or what should we ask him?
It's
When it's an
very,
unknown.
very difficult. Despite what you read about in textbooks and which has been faithfully been copied for so many 100 years, no patient of TB ever complains of night sweats, never complains of weight loss, never complains of evening rise of temperature, never complains of cough. All of this ended in 1950 with Lalita Pawar on that screen coughing away. After that, not a single patient has complained. In fact, most of them are in tears when you tell them that this is likely to be TB. They say, but I've never felt fitter and finer in my life. It is, however, it is impossible to diagnose TB by history anymore. Those days are gone. You need to investigate. However, it is very possible to diagnose autoimmune diseases only by history. So joint pains, especially small joints of the hand and the feet, low backache, extremely sensitive. Every patient you ask, all of them will say low backache, dukta hai, yes. But if you ask specifically, does it worse in the morning and gets better as the day goes by? Only those who are HLA-B21 positive will tell you, yes, that is exactly what happens. Or they'll tell you about stiffness. In the last 2 years, they've been going to some physiotherapist, but it's not getting better. Autoimmune diseases, you need a very good history. But in terms of immunosuppression, it's very difficult. The only thing you can really tell at times is weight loss, changes in the skin texture, changes in the skin tone, color, and that is about it. Otherwise, it's very, very, very difficult. And of course, history, are you taking anything? If you say, are you taking anything, they will assume allopathy. They'll say, no. You have to be very specific. Are you taking any kind of medicine given to you by any doctor whatsoever? Then the packets will come out. From here, from my native place, from here. So then that is very important because you don't know what those contain. I mean, you could know there are 1 or 2 nice labs around which will tell you exactly what it is. But you have to make the effort to find out.
Okay, sir. Thank you.
Yeah.
Yeah,
Regarding the
prophylactic laser. Yeah, who's someone saying? Okay. So because these patients have a tendency of retinal detachment, which is 50 to 60% or either more, there is a class who feel that prophylactic laser is a good enough treatment. Some may not agree to it. And same way prophylactic vitrectomy. But because it is difficult, even if we do a prophylactic vitrectomy, patient may land up again with a retinal detachment or a epiretinal proliferation or retraction. So we cannot guarantee one procedure. So it is a very difficult call to take a prophylactic vitrectomy, because if you tell that even after doing this surgery, you may need one more surgery. So rather the patient may wait, but it is a totally personal call. Though I don't see many people doing a prophylactic vitrectomy in cases of ARN, but the most important complication is retinal detachment. Hence, they have to be under close observation. Even when we are giving intravitreal, we have to be sure that the retina is attached.
So Nadi wants to know back pain.
So what do we mean by prophylactic vitrectomy? Like the disease has occurred already. Why are we calling it prophylactic?
No. It is prophylactic with a view towards preventing detachment, not prophylactic with a view to preventing ARN.
Yeah.
Okay.
So you remove the vitreous because it's the vitreous traction that produces the detachment. No? So
yes,
if there is no vitreous traction, no matter how big a hole you have, it's unlikely to detach. So if you remove the vitreous and remove the ILM, remove all the vitreous traction, and if you then fill it with oil, chances of detachment decrease substantially, but not zero.
Okay, sir.
So Nadi wants to know whether back pains that relief towards the evening, is it autoimmune? It is suggestive. It is not diagnostic, it is suggestive. Almost everybody who has back pain, it is worse in the evening because it's the end of your day's work and you have been slouching all day and stuff like that. So your bad posture tends to become worse towards the evening. But if they complain of pain in the morning and that gets better in the evening, then there's just a suggestion of B27 positivity, because then the morning stiffness is getting lubricated. So things will be better. So Akanksha wants to know, does herpes zoster produce sectoral iris atrophy? All viral autoimmune, all viral anterior uveitis can produce sectoral iris atrophy, all of them. Whether it be VZV, HSV1 or HSV2, all of them can produce. Dayal wants to know whether we'll start oral acyclovir or val acyclovir. Depends on you. If you have admission facilities, better to admit and inject, better to give IV. If you don't have, better to give oral val, no, not vanciclovir, val acyclovir. That is the oral version of acyclovir. It is called Valsivir. The trade name is Valsivir. First line is always acyclovir, whichever way you give it is fine. Anusha wants to know whether CMV anterior-uveitis has high IOP, one of the distinguishing marks, and CMV retinitis has no IOP. Why? Because CMV retinitis does not produce trabeculitis. The problem with CMV anterior uveitis is it doesn't involve only the uvea, it also involves the trabecular meshwork. And one possibility is that the debris, the virus particles and lymphocytes and plasma cells and all also can clog the trabecular meshwork. So therefore they have a high IOP. But once you treat it, it settles very nicely. So any patient with anterior uveitis who has a high IOP, you need to suspect, and not diagnostic, of viral anterior uveitis. It is only
Sir,
a
good
suspicion.
evening, sir. Good evening.
Yes, Nadi, please go ahead.
Sir, I have one more doubt. I asked the same question previously. Like in CMV retinitis, there is no vitritis, you told, no? But
Yes.
In that case also, the viral capsid will be poured into the vitreous, right?
Yeah, but there is
why
some
no
amount of
inflammation?
immunosuppression. There is some amount of immunosuppression now because of low CD4 and CD8 counts. So probably the inflammation in the vitreous does not get triggered, but the inflammation in
Okay.
the retina is getting triggered. Probably because
Okay.
the level of viral
There is no
particles.
enough antibody to produce the inflammation. That's why,
We don't
right?
know. We don't know.
Okay. Okay,
Probably
sir.
the level of viral particles in the retina must be very high as compared to the vitreous. So whatever little immune activity is there is enough to produce inflammation.
Okay. Thank you, sir.
My pleasure.
So Aishwarya,
Yes,
so
sir.
we have given antiviral, right? And you said this
Yes.
is what is the main pathophysiology of the disease? What is the virus causing?
So inflammatory
Inflammation.
pathology.
It is causing inflammation. So how do you deal with the inflammation?
Yes. Yes.
Steroids.
So we can try with low dose steroids.
Low dose steroids
So cannabis should be
or
low
high dose
dose.
steroids? Or no
Ideally,
steroids? I
Steroids should
think,
be
sir, you
started.
do
can
not.
take over.
When you have a classical case like ARN and PORN, there is very little rationale to give steroid. Almost none. Because the moment you start antiviral treatment, it subsides. Really, there is no rationale. In fact, a lot of people feel you should not give because they feel that it might increase make matters worse, might increase the level of inflammation. So if you're sure that it is viral, then better to hold off until you are absolutely sure that the antiviral is not working, then only you get.
Even if we give steroids, should it be after we start the
After we
antiviral
start
therapy?
antivirals, yeah.
After how long of starting antiviral?
At least 24 to 48 hours. At least start looking for evidence of improvement and then you can do what you feel. Signs of resolution, you'll see the retina becomes less white, it starts thinning out, the hemorrhages start to disappear, and usually these don't recur because you have probably killed the virus. So it's rare, recurrences are rare. The moment you start seeing thinned out atrophic retina, you know that things are looking good in terms of resolution of infection.
So regarding the discrepancy in Shermer's test, I was thinking that because there was zoster on one side, maybe corneal sensations were reduced and then that reflex watering was not there or something. Maybe that could be the cause of the discrepancy.
No way of knowing. Maybe it is somebody who's maybe just a technical error doing the test. There's no way to know.
Maybe a false positive.
Maybe a false positive. We don't know.
I think everyone has caught of the Sharmas more than the retinitis.
Really, I don't even do Sharmas anymore. Tear breakup time is so much more easier and specific. Yeah.
It was because he was already diagnosed as dry eye elsewhere. The optometrist picked up and did the Sharmas, and unfortunately, it has come low. And I think no
Look,
one is
we
ready to
shouldn't
ignore
say
it now.
we shouldn't say in front of all these kids and all, but unfortunately, this dry eye business has become like, if you can't find something and you have to tell something, you say dry eye. It's like that. It requires courage to say, no, that I can't find anything wrong with you. Then they'll say, what kind of doctor are you and all that. So you have to say dry eye.
So, sir, for patients who present with scleritis, you still don't like to give them steroids?
Scleritis only steroid and steroid and steroid.
No,
First, to try to
with a
find out
picture of
why.
ARN.
First,
And
to try to find out why. There are 3-4 things that we really need to worry about in scleritis. Most important thing is, in Indian circumstances, rheumatoid arthritis. You have to be very careful that whether this is RA or not. Second is vagus. Again, quite common in an Indian situation. You have to rule out these two. And of course, you have to check inside to make sure that it's not part of some panuveitis picture. But once you have ruled out these two anyway are not going to respond to steroid only. So, but you have to give initially. So RA needs either you like to give methotrexate or HCQS or adalimumab. Same with Wegener's. Wegener needs a much higher level of immunosuppression. So, but you will never see Wegener presenting as scleritis in your OPD.
Right.
This will come to you from some nephrologist who has already diagnosed the patient.
And sir, giving antiplatelets.
I have not tried any of those stunts so far. Sorry.
Yeah, because
I have
they
not tried any of these
component
things
of
so far.
optic neuropathy and occlusive arthritis. Have you
I
ever?
have not tried any of that. Sorry. Really. I don't know if it works also. I really don't know if it works. So anybody has any more questions, then we can take it. No problem. I have all the time in the world. I'm totally free today.
So I think that's a golden opportunity we have. I think anyone having any doubt, Aishwarya? Aishwarya is already treating now ARN.
Sir has answered almost all my doubts. Just that I had that episcleritis doubt that you asked. If any person has episcleritis, should we give steroids in case of this? So that doubt I had just popped in my head. What else?
Anyway, Scorpio girl wants to know in episcleritis, should we start with low dose steroid? You should start with normal dose steroid. What is the rationale for giving low dose steroid? If patient has come to you, you give normal dose steroid, no? If they turn out to be a steroid responder, that's another issue. Otherwise, you give normal dose steroids. Should we go for episcleritis? There is no need to work out the patient at all. Just make sure that there is nothing hiding inside the fundus. And if the fundus inside absolutely clear, you can give normal dose steroids for a few days and only give symptomatic treatment. It's very unlikely that an episcleritis is going to be symptomatic of something. If they get recurrent episcleritis, you need to be sure you're not dealing with RA or some other collagen vascular disease, but that is rare, unlike scleritis.
Recurrent means how many episodes it will be there? From normal episcleritis and collagen vascular disease episcleritis. The
I would
recurrent
say
means how many times?
I haven't tabulated mine, but from what I have read, I would say about in Indian circumstances, about 40 to 50% of patients who come with recurrent scleritis, recurrent, not one episode you treat and it disappears for life now. Patients who come with recurrent scleritis, I would say 40 to 50% are some grade of RA. Some grade of RA. Vishal, the rationale
So what
is
about episcleritis? Scleritis, okay, sir. But even episcleritis can be related to RA? It is less correlated, no?
much
When
less
compared to
correlated. Much less correlated. I don't do any such correlate. I don't even take up history. If I see episcleritis, I just give Pred Forte for a few days and finished. Rationale for giving 1 gram versus 2 gram TID, I've never given 2 grams. I've always given only 1 gram Valsivir. Even my hospital infectious disease consultant only advises me to give 1 gram TID of Valsivir. Whether no matter how bad the herpes zoster ophthalmicus is or HSV is, we never crossed more than 1 gram TID. If he's not responding to 1 gram TID, I immediately send it to him and he manages from there on.
But even if you are giving 2 gram, it is only for the induction phase. So you have to reduce it after 2 weeks. You cannot go on for 2 gram for a long time because these are again toxic. So your patient may land up with ARF, and again you have to tell the patients to keep up their hydration and drink plenty of water. Okay, so there are some people who give 2 gram as well, but again there is no protocol as such that which one to go for. If it works with lower dose, that is good enough.
So to check for response to treatment after the 14 days, what we have to look for? Only that is reduction in the clinical findings or any other blood test we have to do?
No, there's nothing you can do. You just have to observe clinically. Look for reduction of inflammation of the retina. You will see that the retina becomes very thin, atrophic. Holes can start developing in the periphery. You will start seeing sheathing of the vessels. The vitreous will start becoming clear.
So as sir said, this is majorly a clinical diagnosis. You may investigate with PCR if there is no response or if you have facility, but this you have to start the patient on antivirals as soon as you see him because it is a rapidly progressive disease.
The most important thing is to protect the other eye. Most important thing. Even if it turns out later that you were wrong, there is no harm in giving 2-3 days of acyclovir seriously. Just explain to them that you feel it is this and you want to make sure it doesn't occur in the other eye, therefore you're giving this.
So So Aishwarya, does it involve the veins more or the arteries more?
Sir, arteries are involved more.
Very nice. So this is very important point. Even for
Yes.
questions, the arthritis, because they ask for vasculitis. So
Right.
generally you tend to forget that which disease. So
Which is
ARN is classically arthritis.
arthritis. And so
Yeah.
is toxo mostly involving the veins?
Yes.
Toxoplasma involves the veins
It is
more.
rare, but yes, you will have a involvement of vessel around the lesion, and you can have arthritis. Sir, you want to take over, sir?
Yeah, no, it's classically an arteriolitis. Classically. So
Okay.
there are 2-3 things which are classically an arteriolitis. One of them is ARN, the other one is Behcet's. Behcet's. Very, very important.
Yes, Behcet's.
Therefore, all patients who get Behcet's have a very, very high risk of severe visual morbidity because of the severe arteriolitis. So if you see patients who get primarily periphlebitis, like those with TB, sarcoid, the fundus can be studied with vascular lesions and lesion is still 6/6. They're happy. They don't even know. But not patients with Behcet's and with, of course, autoimmune arterial diseases. Okay, Anuj, anything else or can we call it a day?
I think Aishwarya, anything? Anyone, anything? I think Arun has.
Yeah. Arun, sheathing of vessels is neither a good sign nor a bad. It's just a clinical sign. That's all. You don't even, it's neither a sign of vasculitis nor is it a sign of anything. You can get sheathing of vessels even in hyperlipidemia. Doesn't mean anything. How frequent do you order CD4 counts in immunocompromised patients with ARN? Generally, ARN patients are not immunocompromised.
No compromise.
PORN patients are. I routinely get CD4 done every 3 months. But usually these patients are always under the care of an infectious disease physician or an HIV physician or somebody. So they order according to their own protocols. So you don't have to worry. They're not going to come to you for this.
So, any more doubts? I think we've taken too much of time from sir.
No, totally free. No problem.
Sir, if there is PORN and if we are giving